What should we know about a patient who potentially has primary biliary cholangitis, and how do we approach them? So in a primary care setting, I often get these kinds of questions that I want to just share with all of you today. The question is, what do we do for a isolated elevated alkaline phosphatase? Well, what we have to do for an isolated alkaline phosphatase elevation is, number one, make sure that the patient does not have any bone component. You can fractionate alkaline phosphatase. You can also do and should be doing a ultrasound of the biliary tree and pancreas. And in particular, what we should be doing is that to just make sure that there's no stones or obstruction that can be causing the problem. So again, when we're talking about primary biliary cholangitis, it's a disproportionately elevated alkaline phosphatase to transaminase. When we have that and we have the ultrasound that does not show any sort of evidence of obstruction whatsoever, there are a couple of other tests that we need to go to. And one is called the anti-mitochondrial antibody that we all remember back from school. Anti-mitochondrial antibody is the go-to test to help confirm that diagnosis. Anti-mitochondrial antibody is going to be positive in the vast majority of patients with primary biliary cholangitis. However, we also do, as a backup test, just to make sure, and in case the anti-mitochondrial antibody is negative, we do an anti-nuclear antibody as a backup test, because sometimes that can be positive and the anti-mitochondrial antibody test can be negative. So once we have that information, how far do we need to take this? So what we need to do is always, once we have that basic information in a primary care setting, then we're going to present this information to the gastroenterologist or the hepatologist in your area, and we can talk about the progression of medicines that would be appropriate under those circumstances. Do those patients all need liver biopsies? No. These days, liver biopsies are pretty rare under these circumstances, but your gastroenterologist or hepatologist may make that recommendation. The other key element that I wanted to tell you about is the medicine armamentarium is changing. There are a whole bunch of medicines that we used to give in years gone by that may or may not be effective. But your gastroenterologist or hepatologist will have a series of new ones to provide additional backup, because 30% of patients who receive the initial medications may not have a response. The new medicines are out there, they're available to you. So the key here, work with your hepatologist or gastroenterologist to assure the best possible response for your patients.